Next topic, everybody. Secondary glaucomas. Glaucoma which is occurring due to some other cause already existing in the eye. The first thing that we discuss here is lens-induced glaucoma. Lens-induced glaucoma can be of three types. The first, if we remember the name through the lecture on lens, everybody, phacolytic glaucoma. Phacolytic glaucoma. The cause of this glaucoma was Morganian cataract. This though we already know, guys. The most common complication of Morganian cataract is phacolytic glaucoma. Why am I mentioning this to you here is I'm trying to ask you, phacolytic is which type of glaucoma? Is it a secondary angle closure glaucoma or secondary open angle glaucoma? Think about it. Focus on the name, phacolytic. Lytic means breakage. Lens is breaking. When the lens is breaking, it is creating some kind of a residue. That residue will go and block the trabecular meshwork. So it will be open angle glaucoma. That's what I said when I explained open angle glaucoma. Whenever there is some residue, kachra or garbage, then it will be open angle. So the funda is very simple. In any secondary glaucoma, just think kachra forming yes or kachra forming no, garbage yes or garbage no, residue yes or residue no. If there is residue, it will be open angle, otherwise it will be angle closure. Now, the second lens-induced glaucoma is phacomorphic glaucoma. Phacomorphic glaucoma is caused by intumescent cataract. Intumescent cataract. If you understand by the name intumescence means swelling, swollen lens, intumescent cataract. Yes, guys, lens has become swollen. So when the lens will become swollen, what will it do, everybody? The swollen lens, everybody, this is the normal lens. The swollen lens, everybody, will start to touch my pupil. Thus, it will become the same as secondary angle closure glaucoma. Yes, apposition between pupillary margin and lens. Then the third, everybody, is phacotopic glaucoma. This occurs in cases of, again, we have discussed this in the chapter lens, microspherophakia. Microspherophakia, small and round lens. The small and round lens will try to jump through the pupil, everybody. The pupil will catch it. Again, pupillary and lens apposition. So again, it will be a case of secondary angle closure glaucoma. You understand? Small and round lens trying to jump through the hoop, everybody. The pupil will catch it in between, angle closure glaucoma. Done? These are the three types of lens-induced glaucomas, everybody. Think garbage yes, garbage no, answer. Now, another pathology that we want to discuss as a secondary glaucoma is pseudo exfoliation glaucoma. Pseudo exfoliation glaucoma. If I just mention the name and ask you which type of glaucoma it is, what will you say? Open angle or angle closure? Think about it. Garbage yes or garbage no. Exfoliation. Focus on the word exfoliate, exfoliate, exfoliate. You use exfoliative scrubs to remove the dead cells. Yes? So exfoliation is basically formation of some residue, kachra. So kachra will again mean secondary open angle glaucoma. This type of glaucoma, everybody, occurs due to LOXEL1 gene mutation. Clinical features apart from glaucoma. This shows a sign which is called as target sign on the lens. Target sign. From some places, the anterior capsule of the lens will exfoliate. From other places, it will not. Okay? So, everybody, if we see this photograph, this is the target sign. In the center, there is a ring. The second zone is clear, and then there is deposition of exfoliative material. So it looks like a target, yes or no? There is blur, clear, blur. Now, secondly, we can see something called as phnocks. Phnocks are whitish deposits on pupillary margin. Whitish deposits on pupillary margin. All the exfoliative material that is accumulating will get deposited on the pupillary margin also. So as you can see in the image on the right now, there is whitish deposition all over the pupillary margin, and this is known as phnocks or knocks. Then, apart from these two, another important sign is poor mydriasis. Pupil is not able to dilate. Then, Sam-Paulesi line. Sam-Paulesi line is deposition anterior to Schwab's line. The exfoliative material which is going into the angle of anterior chamber is blocking the trabecular meshwork. It is also getting deposited just near the Schwab's line, which is known as Sam-Paulesi line. Okay, everybody, done? So important clinical features, 2 photographs, pseudo exfoliation glaucoma. Now, moving on to another condition causing secondary glaucoma known as pigmentary glaucoma. Again, from the name I will ask you, pigmentary glaucoma, which type of glaucoma does it look like? Pigment is a residue from the word, so pigment will block the trabecular meshwork. Open angle glaucoma. Now, pigmentary glaucoma is more common in myopes who are males and are young. Okay? MY, myopes, male, young. Now, what are the clinical features? Clinical features are Krukenberg spindle. Krukenberg spindle. See, wherever the pigment gets deposited, it will be visible. So, it gets different names. Deposition of pigment on corneal endothelium. So, the pigment which is getting released in this pathology is getting deposited at a lot of other places apart from trabecular meshwork. On corneal endothelium, spindle shaped, long, known as Krukenberg spindle. Secondly, Zenta-Meyer line. Zenta-Meyer line. Zenta-Meyer line is deposition of pigment on posterior surface of lens near insertion of zonules. Where the zonules get inserted onto the lens, right about there. This is characteristic, diagnostic of a case of pigmentary glaucoma. And thirdly, just like pseudo exfoliation syndrome, Sam-Paulesi line. Okay? Now, the next condition that we want to discuss in this is steroid-induced glaucoma. As all of us know, steroids can lead to glaucoma. Let's discuss just a little bit about steroid-induced glaucoma. Okay? Steroids cause glaucoma due to excessive production and decreased destruction of extracellular matrix of trabecular meshwork. So there is more deposition of GAG, is extracellular matrix, everybody, because there is more production and decreased destruction. This basically leads to which type of glaucoma? This leads to secondary open angle glaucoma. There are various theories as to why it occurs. This is the most commonly accepted: increased production and decreased destruction of extracellular matrix of the trabecular meshwork. Now, it is not that everybody who is being given steroids will develop glaucoma. We say that there are some people who are called as steroid responders, some called as non-responders. So steroid responders can be grouped into three everybody: high responders, moderate responders, or non-responders. Okay? Patients who are high responders, they have greater than 31 mmHg of IOP, obviously after steroid has been given to them, or greater than 15 mmHg increase in IOP after steroids have been instituted. Moderate have 25 to 31 mm of mercury IOP, or 6 to 15 mmHg increase in IOP. Non-responders, their IOP even after steroids remains less than 20, or there is a increase of less than 6 mmHg. Am I clear? So once you have given steroids, you need to see which category does the patient fall in. If the patient is a non-responder of steroid, it is safe to prescribe steroids. But if the patient is a high responder, you can't. Now, if steroid is leading to glaucoma, high responder, we need to treat the glaucoma, everybody. The treatment is done by beta blockers or by laser trabeculoplasty. See, the problem is in trabecular meshwork. It is an open angle glaucoma. So the treatment will be on the lines of open angle glaucoma. Nothing to explain here, guys. Okay? Now, the next secondary glaucoma condition that we study is known as malignant glaucoma or ciliary block glaucoma or aqueous misdirection syndrome or inverse glaucoma. One condition, four names, guys. Malignant glaucoma or ciliary block glaucoma or aqueous misdirection syndrome or inverse glaucoma. Each name has something important to learn. This glaucoma is called malignant glaucoma because the cause is incisional or laser surgeries. Due to some kind of surgery in the eye, this glaucoma develops. What is the mechanism? The mechanism is anterior rotation of ciliary processes which leads to ciliolenticular block. Ciliolenticular block. Let's try to understand this. Normally, my ciliary processes are directed slightly posteriorly. Okay? This is where my lens is. So there is some space between the lens and the ciliary processes. But now what is occurring, everybody? There is anterior rotation of these. So they become like this. Okay? Due to the anterior rotation, everybody, okay, like this, now they are rotating like this. they will start to touch the lens. There is ciliolenticular block. Yes? Now, due to the ciliolenticular block, what is occurring? The whole, now I can say the lens as well as the iris is moving forward. Why? All the aqueous that is getting secreted in the PC. But some of the aqueous also starts to get secreted behind the posterior surface of the lens. So all this gets pushed forward. When all the iris and the lens, everything gets pushed forward. So let's say now the iris will reach here, my lens will reach here. So when everything gets pushed forward, everybody, it will lead to angle closure glaucoma. Do you understand this? If I write it, due to the ciliolenticular block, there is posterior flow of aqueous. Thus, the whole iris lens diaphragm gets pushed forward. So you understand why, guys? Because the ciliary processes are touching the lens, everybody. Some of the aqueous which is getting secreted behind the now lens is pushing everything forward. When it will push everything forward, it will lead to secondary angle closure glaucoma. But if you realize, everybody, even though angle closure glaucoma is occurring, there was no pupillary involvement. So we say without pupillary block. The pupil is not touching the lens in this case. There is no pupillary block. I hope you understand. Whatever angle closures we have discussed till now, the pupil touches the lens. Yes? Now, because there is no pupillary block, when I ask you the treatment, everybody, normally the treatment was pilocarpine, because we wanted to break the attack of angle closure glaucoma. But here, pilocarpine will be of no use. Here, instead, we need to give atropine, cycloplegic. Cycloplegic, it will relax the ciliary muscle. When the ciliary muscle gets relaxed, it will pull the ciliary processes a little away, a circular muscle, everybody. Yes? So the ciliolenticular block will be broken. The drug which needed to be given in angle closure glaucoma is pilocarpine, but we are giving the opposite drug, everybody, atropine. And that is why this gets the name inverse glaucoma. I hope you understand. Malignant glaucoma because of the cause, ciliary block because of the pathogenesis, aqueous misdirection because now the aqueous is getting secreted posteriorly also, and inverse because the treatment is opposite. Okay? So, relaxation of ciliary muscle will lead to stretching of zonules. Derive it from the accommodation, everybody. Muscle contracted, relax zonules. But when muscle relax, zonules have to stretch. When the zonules will stretch, they pull the lens back. Okay? So they will pull the lens back and thus they will break the ciliolenticular block. Am I crystal clear here, everybody? That's all about my malignant glaucoma. That's all about my secondary glaucomas. We just need to understand the mechanism, then answer open angle or angle closure and some associated clinical features along with. Okay? Now, if you understand, everybody, till now we have discussed the glaucomas which occur in adults, everybody. The primary open angle, angle closure and the secondary. But can't glaucomas occur in children? Yes, they can occur. So our next topic, everybody, is childhood glaucoma. Okay? Now, childhood glaucoma. Glaucoma occurring in children. This can be divided into three types. Newborn glaucoma, infantile glaucoma, and juvenile glaucoma. Newborn glaucoma, the onset is at birth. Infantile glaucoma, from birth till less than 3 years of age, and juvenile glaucoma 3 to 16 years of age. Newborn glaucoma forms 40% of the total caseload. Infantile forms 55% and juvenile only 5%. Okay, so I can basically say that newborn and infantile together make up almost all the cases of childhood glaucoma, and together they are known as primary congenital glaucoma. Primary congenital glaucoma. Okay, now, so that's the topic we are trying to read, primary congenital glaucoma. We know now that for primary congenital glaucoma, the onset is less than 3 years of age, either newborn or infantile. What is the mechanism? If it is congenital, there has to be some kind of malformation since birth. Trabeculodysgenesis. Trabeculodysgenesis. 2 words. Trabeculo means trabecular meshwork. Dysgenesis means malformation. When the child is born, there is some issue in the formation of trabecular meshwork. Thus, I can ask you, primary congenital glaucoma is which type of glaucoma? Open angle mechanism or angle closure mechanism? Everybody, because of the word trabecular meshwork. I hope this is not a difficult thing at all. Open angle glaucoma. Now, after we know the mechanism, what are the symptoms, everybody? So the symptoms we say is a triad. It's a triad. 3 symptoms occur together. Can be remembered by the mnemonic BPL. BPL. BPL is an electronics company, everybody, or below poverty line, BPL. Okay. B for blepharospasm. P for photophobia. And L for lacrimation. L for lacrimation. Okay. Photophobia is generally accepted to be the earliest symptom that the child will present with. Okay. Done. Blepharospasm, photophobia, lacrimation. Now, what are the signs? Let's move on to the important stuff. Signs. Number 1. The first sign, the earliest sign that is always noted is hazy cornea. Hazy cornea. Why? See, understand, an infant's eye or a child's eye is not completely formed. The basic difference being that the eye is still distensible. Yes? The eye is small in a child and it will slightly grow in size to attain the size of an adult eye. So child's eye is still stretchable or distensible. Now what is occurring? Glaucoma, increased IOP. The increased IOP is pushing everything out. So a small eye which was slightly elastic, distensible, stretchable, due to the excess IOP is stretching at a much faster rate than normal. Now imagine if I take this shirt and if I stretch it, if I keep on stretching it, what will occur? The shirt will start to develop some tears. Yes? The same thing occurs in the eye. When the eye is stretching, everybody, something starts to break. Focus on the cornea is stretching. When the cornea is stretching, some of the layer of the cornea will break. Which layer should break first? The pressure is coming from inside. So the inner layer should break or the outer layer, everybody? Inner layer. What is the innermost layer? Endothelium. So because the endothelium will break, the transparency will be lost. The tight junctions between the endothelial cells will not be able to contain the aqueous and there will be hazy cornea. Do you understand this? Second sign. Harb's striae. What are Harb's striae? Horizontal or concentric breaks in Descemet's membrane. Horizontal or concentric breaks in Descemet's membrane. Just keep thinking about the story. The cornea is enlarging. The first layer to break was endothelium. What is the second layer from inside? Descemet's. Now Descemet's membrane will break. It will show fine breaks, everybody, striations, fine breaks, and those breaks are known as Harb's striae. Sign number 3, guys. Two layers have broken, but the IOP is still pushing the eyeball. The eyeball is continuously distending. So ultimately, you will see that the eyeball has become larger than its size, which is known as the characteristic word. If you have ever heard it, guys, I hope you have. Ophthalmos, enlarged eyeball. Yes, the whole eyeball becomes more in size, enlarged than the usual. How will you be able to diagnose whether it is an enlarged eyeball or not? What is the structure you are able to see? You are able to see the cornea. So let's measure the diameter of the cornea. Corneal diameter is characteristically greater than 13 mm. Normally, it is around 10.5 mm. Okay? So when you measure the corneal diameter, it will be increased, telling you that the cornea has grown in size. Secondly, even the sclera is getting stretched out. Yes? So when the sclera is getting stretched, you are stretching it. So sclera is getting stretched and it is becoming thinner. So scleral thinning is occurring. Due to the scleral thinning, everybody, you are able to see the deeper blood vessels in the uvea, which is giving you a bluish appearance. So you say that the sclera has become blue. You say that the sclera has become blue. Okay. Now imagine, everybody, the sclera is blue and the cornea is hazy. A hazy cornea will also give a grayish bluish color. So try to imagine the whole eye will look blue. So if I show you this photograph, what is the song that comes into your mind, guys? Yo-Yo Honey Singh. Blue eyes hypnotize teri kar di hai mainu. Yo-Yo Honey Singh saw this photograph, then only made that song, guys. So very clear cases of blue eyes, but please don't get hypnotized. This is a case of congenital glaucoma. Very clear, very easy to be able to diagnose this case. Am I clear to everybody? Now, let's move back. Sclera will be stretching, blue sclera, cornea will be enlarged. Okay. But because the whole eyeball is becoming large, the anterior chamber will become deeper than normal. Common sense. Everything is becoming large, so everything will become deep. And when the whole eyeball gets enlarged, there is resultant myopia. So the child will be myopic, right? So these are the findings you will be able to see due to ophthalmos. These are the signs important that you will be able to see in case of a congenital glaucoma. But if it is a glaucoma, you may also want to do what, everybody? Gonioscopy. So what are the gonioscopic features? There are 3 gonioscopic findings characteristic for congenital glaucoma. First of all, on examination, the iris is inserted anteriorly, anterior to the normal position of insertion of iris. Okay. Secondly, there is a membrane which is covering the trabecular meshwork, pretrabecular mechanism, Barkan membrane. Then there is something called as Loch Ness monster phenomena. Loch Ness monster, guys. I don't know if you have read those fairy tales. So there used to be a fairy tale in which the sea became a monster, like this, all those curved, so sea waves will become like this, everybody. So this is called a Loch Ness monster. When you see the angle structures, there are blood vessels like this looped over each other, which look like a Loch Ness monster. And thus it is called as Loch Ness monster phenomena. If you don't know what is Loch Ness monster, I don't expect you to read the fairy tale again. You can even watch a movie called Moana. Yes, Moana of Montaigne. It's a very good animation movie. If you have time, though you should not have time, guys. Anyways, just a little bit of fun. Loch Ness monster phenomena. Loops of vessels are seen. Right, guys? These are the gonioscopic features. Now, once we know the features and everything, what we need to do is we need to treat this case. So for treatment, please remember that the treatment of choice is, the problem is in trabecular meshwork. Yes or no? Trabeculodysgenesis. So please try to derive the answer. The answer will be trabeculectomy plus trabeculotomy. If you do not remember the answer, at least try to apply common sense. Try to focus on the word trabecular meshwork. Okay? But if in congenital glaucoma, patient presents with clear cornea. See, understand why is this becoming an if. We normally say that the earliest sign of congenital glaucoma is hazy cornea, but there are a certain subset of cases which will present with clear cornea. In that case, we say the treatment changes to goniotomy. Okay? Using a gonioscope, you can do a less invasive procedure, and that becomes the treatment of choice. So the only thing to notice is the word clear cornea in the question, which will change the answer. Right, guys? That's it about my topic, primary congenital glaucoma. It is very easy to remember. The childhood glaucoma can present in 3 ages: neonate, infantile, or juvenile. Then primary congenital glaucoma presents in less than 3 years of age. There are 3 symptoms, B, P, L. There are 3 main signs, hazy cornea, Habs-Tri, Boop-Thalmos. There are 3 gonioscopic features, anterior iris insertion, Burkan membrane, and Loch Ness monster phenomena. So everything is 3, guys, okay? So just remember everything 3 and you should be able to do it. Now, to finish our chapter on glaucoma, we have done primary congenital glaucoma. What about secondary congenital? Congenital can also be due to some other disease, or as it is known, developmental glaucoma. So the last topic, secondary congenital or developmental glaucoma. First of all, as is clear from the name, it is due to some other disease. Secondly, there is an inherent difference in the mechanism of primary congenital and secondary congenital. Primary congenital was due to trabeculodysgenesis, but secondary congenital glaucomas are due to irido-corneo-trabeculodysgenesis. That means, in cases of secondary glaucoma, even the iris and the cornea are affected along with the trabecular meshwork. Am I clear? So please note this specific point can be used as a question. Now, what are the important causes or the conditions which cause glaucoma? The first important condition is everybody, Sturge-Weber syndrome. Please remember, questions are asked. What is the manifestation of Sturge-Weber syndrome in the eye? Okay. Secondly, everybody, another important cause is aniridia, absence of iris. Absence of iris can also lead to glaucoma in almost 75% of cases. Thirdly, everybody, another important cause is Axenfeld-Rieger syndrome. Axenfeld-Rieger syndrome. And then lastly, Peters anomaly. So just remember these 4 important names. There are other causes also, but these are the usual things that I want you to remember. And please remember the small difference between primary congenital and secondary congenital glaucoma. That's it about the types of glaucoma, everybody. That's it about glaucoma. If you have been able to understand, again, there is a flow, there is a story. First of all, what is glaucoma? Then secondly, how does glaucoma occur? Then the clinical part, if you suspect glaucoma, how to investigate it, ophthalmoscopy, perimetry, tonometry, gonioscopy, 4 things. Then the types of glaucoma, primary and secondary. Primary open angle, primary angle closure, secondary in adult, primary congenital, and then secondary congenital. So please make it a story. Everything comes after the other. If you don't know the first part, it becomes difficult to remember the second part and thus the third part. So please take it as a flow. In all the chapters, I try and tell you a story. It is easy to read novels. Why? Because they are a story. Try to think of each chapter as a story. Build a story around it and you will like it. You will learn it. You will enjoy learning it.